Okay, everybody, thanks so very much for being here. I'm Dr. David Morwood. I'm a plastic surgeon here in beautiful Monterey, California. And maybe you met my wonderful staff. That's Laura, and that's Raina, and that's Angel. So this series is called The Truth About Plastic Surgery. We started this a number of years ago for people in the beauty industry, hair cutters and salon workers. Oh, that's you. Wow, thank you for coming. And as you know, a lot of people probably come to you and ask you for advice. So we started it for those workers, and we expanded it to the public, basically because of popular demand. And we do one on eyelids, we do one on neck, we do one on face. Today we're going to talk about plastic surgery of the breast. We give this talk every October, Breast Cancer Awareness Month, but we also try to do it during the summer as well because plastic surgery of the breast is so popular. It's a big part of my practice. Sometimes people come in and they say, Dr. Morwood, I know you do a lot of breast reconstruction following breast cancer treatment, and I know you go overseas and operate on kids, etc. I feel kind of vain talking to you about cosmetic surgery. Actually, it's normal, natural, healthy to be concerned about one's appearance. We all want to look our best. That's part of our DNA. I think it's a very healthy part of our DNA, actually. Sometimes people say, is it the reason, or is the reason you call it plastic surgery because you use a lot of silicone or plastic? Actually, it's because the root, plastikos in Greek, means to mold, shape, and tailor. And that's what we do in this specialty. So today, we're going to talk about plastic surgery of the breast, as I said. The cosmetic part of plastic surgery of the breast really has three essential approaches. Augmentation, which is making breasts bigger, fuller, and rounder. There's reduction, which is making breasts smaller, higher, and lighter. And then there's mastopexy, which is lifting. And of course, there's combinations, and we'll talk about those as we go. And then I'm actually going to talk about plastic surgery of the chest wall and breasts for men, and also we're going to touch on breast cancer reconstruction. So what about breast augmentation? First of all, everything we do in plastic surgery has pros and cons. There's advantages and disadvantages. Anything we do in plastic surgery and in life has advantages and disadvantages. So I like to tell women and teach women about the pros and cons of breast augmentation. In one day, here are the what we call the pros or the advantages. In one day, safely, your breasts are made bigger, rounder, fuller, and slightly higher. Bigger, rounder, fuller, and slightly higher. That's what breast augmentation is. However, there are some downsides. There's a possibility of some cons. Mainly, it's because implants are used most of the time. Implants can be felt. Sometimes the outline of implants can be seen. Capsular contracture can occur. That's when the normal scar tissue around an implant gets thick and heavy and starts to contract and squeeze. Hi there.
Hi.
Come on in. We've got plenty of room.
Oh, good.
Please join us. Come on in. Have a seat.
In the front row, but we'll
Why? The front row.
I'm sorry we're late.
Oh, it's perfectly okay, and we're going to save some beverages and food and treats for you for afterward, okay? We'll get to chat. So, as I said, breast augmentation. So we're talking about plastic surgery of the breast today. We're going to talk about breast augmentation, breast reduction, breast lifting, breast reconstruction, and actually plastic surgery of the chest and breast for men as well. So we talked about there's pros and cons to everything that we do. The advantages to breast augmentation are you get to be bigger, rounder, fuller, and slightly higher. The downside is implants. Most of the time implants are used. I am going to talk about the so-called natural way we do breast augmentation. That's with a woman's own fat grafting. However, most of the time implants are used. Implants can be felt. Sometimes the outline can be seen. Capsular contracture is important for us to talk about. Capsular contracture is when the normal scar tissue that forms around any implant in the body starts to get thick and heavy, sometimes calcified, and squeezes. And that makes the implant feel hard. The implant actually hasn't changed, but it makes the implant feel hard. It's important for us to talk about because probably capsular contracture is the single most common long-term downside to breast augmentation. It's not always bad. Nothing necessarily has to be done, but it's something that we do have to talk about. It's possible for implants to leak, possible that they can become infected, extrusion, migration can occur, possibility of a change in nipple sensation. Nationwide, about 15% of women either get more sensation for the nipple or decreased sensation, 15%. And of course, special surveillance is needed. You need to do self-breast exams, get special mammograms, etc. So, as I said, the most common complication of breast implants long-term is capsular contracture. Yes, ma'am.
On the possible change in the sensation, is that also, if you just happen to lift, does that still affect that area of the breast?
Okay, so depending on what approach that we use for the lift, and I'm going to talk about mastopexy, which is breast lifting, it really depends on the approach. When we do breast reduction, it's more common to have a change in nipple sensation. Breast augmentation, about 15% of women nationwide. It doesn't happen so often with mastopexy. Basically, mastopexy is a skin operation with some lifting on the inside. But that's a great question. Thank you. Okay, so the plastic surgeon's job. What's my job? We want to do an excellent operation. Of course, that's my number one job. But I also want to help the patient make decisions and choices to tilt the balance in her favor. We talked about the advantages. You get to be bigger, fuller, rounder, and a little bit higher. And then there's downsides that sometimes you can feel the implant, see the outline, capsular contracture can occur, etc. So there's all kinds of decisions to be made. And my number one job is to do an excellent operation, but number two is to help the woman ahead of time make decisions to tilt the balance in her favor towards the positive and advantages and away from the disadvantages and downsides. So, what are just some of these decisions to make for breast augmentation? There are 4 different incisions that we can make. The armpit, underneath the areola. The areola is the tan part around the nipple. In the inframammary fold, that's the most common approach. And then there's even through the belly button. That's not so commonly done. There's 4 different incisions. We can go above or under the muscle, the pectoralis muscle with the implant. We can go textured, smooth, round, teardrop shape, many different types of implants available. There's almost unlimited sizes, but we need to emphasize we cannot predict cup size. All bra manufacturers are different. Johnson & Johnson is different from Playtex, Cross Your Heart, Victoria's Secret. So there's no uniformity to cup size, so we can't really predict cup size. There's many different manufacturers, etc. One of the take-home lessons that I want to provide you is that there's a custom-designed approach. You may go on the internet and read about some places you can go and you get in line and everybody gets the same thing. In this office, it's a custom-designed approach. Every woman gets a different operation because everyone comes with a different set of breasts and a different type of skin and a different desire, etc. So there are personal decisions to be made. Of course, getting a breast augmentation is a personal decision, but there are essentially 2 personal decisions for you to make, and I can help you make all the rest. Above and under the muscle, different incisions, etc. A woman needs to choose between silicone and saline. Now, all implants have the shell on the outside of silicone. Every shell is made of silicone. It's firm. It's a shell. What is filled on the inside is different. It can be salt water, or it can be silicone. And decide your approximate size. I like women to bring pictures that they think breasts that they think would look good on them. We have different things, different ways we can help you. We have the vector computer analysis here, which is very helpful. But there's essentially two personal decisions for women, and that's, do you want saline or silicone, and what size do you want to be roughly? So there's all kinds of choices to be made. Saline, silicone, moderate profile, high profile, textured, smooth, round, teardrop shaped, etc. On and on and on. Above the muscle, below the muscle. I can help you with those decisions. Now, I want to show you some examples. I've done so many of these cases. I don't want to bore you. But for example, here's a woman who came and she got silicone implants under her muscle through inframammary fold incisions. Now, she started off with a little bit of asymmetry in her nipples, and she has it afterward. And that's something that I need to emphasize, is that we make your existing breasts bigger, fuller, rounder, and a little bit higher. When we want to start to change the position of the breasts or the nipples, then we start talking about mastopexy and shaping, etc. So, again, all kinds of different ways to do this. We can go saline under the muscle. In general, silicone can go above the muscle or under the muscle, but saline almost always goes above the muscle. Now, some women have some constriction, so she got a little bit of a mastopexy. I'm going to talk about that later. Mastopexy is when we move the position of the nipples or change the breast mound. And as I said, different approaches. We can go through the armpit. We can go just under the areola. infraperineal approach or in the inframammary fold. Breasts come in so many different sizes and varieties. So again, during our consultation, we can talk about the approximate size you want, whether you want saline, silicone, above the muscle, under the muscle, etc. So one of the take-home lessons I want you to get from here is with a breast augmentation, I've said you get to be bigger, fuller, rounder, and a little bit higher. Just by putting in implants, you get a little bit of auto rotation. If you think of a girl on a swing, as she gets higher, well, she moves forward on the swing, she moves up a little higher. And that's exactly what happens to the nipple. So the implant, you have to give the implant time to cup. That's another important take-home lesson. Whenever we do breast augmentation or any kind of breast surgery, I always remind women you can't judge right away. You have to give it a few weeks or a few months to soften and settle and cup. And that's certainly true with breast augmentation. And you get a little bit of auto rotation. So with breast augmentation, you get to be bigger, fuller, rounder, and a little bit higher. If you need to be a lot higher, then we talk about a mastopexy. So everybody's different. This gal, I think, decided to go through the armpit. Sometimes women decide to go to the inframammary fold underneath. So you get to be bigger, fuller, rounder, a little bit higher. Now this gal had a little bit of a lift, as you can see, mastopexy. This gal has very little breast tissue, so in general, if a woman has very little breast tissue, we tend to go under the muscle, or certainly we use silicone implants. Saline almost always goes under the muscle. So if you have pre-existing asymmetry or differences, you're going to have some afterward, and that's something that we talk about. So bigger, fuller, rounder, a little bit higher. Difficult to predict the cup size that you're going to be. Okay, so in summary, that's breast augmentation with the use of implants. That's when we take a saline implant or a silicone implant. 4 different incisions can be made. We can go above the muscle, under the muscle. Sometimes we do a lift, sometimes we don't, etc. It all depends on what you need. Those are implants. And there's pros and cons of everything we do in plastic surgery. There are pros and cons of using implants. Now, what about fat transfer for breast augmentation? That's the so-called natural way of breast augmentation. I just want to check on the time. I hope I'm not wearing anybody out. So, what is fat transfer? Fat grafting. Fat transfer or fat grafting is when we do a little bit of conservative liposuction, generally from the trunk around the tummy, and we spin it down or centrifuge it. Sometimes we decant it. We keep it sterile. Sometimes we surgically cleanse it, and we inject it somewhere else. So for breast augmentation, we can inject it into the breast. We can do it for the buttocks. We can do it to give somebody, a man or a woman, higher cheekbones, to bring the chin forward a little bit, to better accent the angle of the jaw. So those fat cells are like little apple seeds, like Johnny Appleseed going around planting apple seeds all over New England. We overcorrect because about 67% of the volume persists. About 33% will atrophy. But it's your own cells. It's you. We also bring up some estrogen receptors. It brings up a little extra blood supply. In fact, we do bring some stem cells, so it can help rejuvenate the skin, rejuvenate the surrounding tissue. But essentially, it's a volume replacement. So I do this a lot with neck and facelifting for higher cheekbones, etc. It helps to rejuvenate tissue. So we do it for the buttocks, we do it for the breasts, etc. So fat grafting to the breast. It uses a woman's own tissue. In general, it results in a moderate increase in breast size, and of course it can be repeated. So this is in the operating room. Oh, I should back up a little bit. For small areas, we do that right in the office when someone's awake. We do a little conservative liposuction, decant the fat or spin it down, and we can graft it. Higher cheekbones, bring the chin forward, etc. Sometimes we fill in a depressed scar. Usually for breast augmentation or buttock augmentation, that's a lot of volume. We do a lot of liposuction, a lot of fat grafting. So someone needs an anesthetic, either at the surgery center downstairs or at the outpatient surgery center of the hospital. So for example, here's a gal who wanted just a slight moderate increase in her breast size. She did not want implants, so she elected to have fat grafting. So you get a moderate increase, and it's her own breast tissue. For some women, we have them do the Brava system. That's some suction cups for a couple weeks prior. It's a little suction device to help get the tissue ready. It opens up new channels. Then we do that. So here she is before, There she is after, following fat grafting. Here's a gal who wanted liposuction, and she also wanted bigger, fuller, rounder breasts. There she is, immediate. Now,
She's big.
see, the reason I'm showing you this is because we overcorrect. Only about 67% persists. So for this gal got some lifting and some fat transfer. So again, recall that I said this is a custom designed approach. Sometimes women get a lift. Some women want fat grafting. Some women want implants, silicone, saline. The sky's the limit. So that's why in consultation everybody spends time with me. Everybody gets to meet my staff. We have the Vectra computer analysis. That's a great piece of equipment, $40,000 piece of equipment. It helps you to communicate, and it can give you some idea about the result from your surgery. Okay, here's one of my favorite Rodin sculptures. So I've talked about breast augmentation with implants or your own tissue. What about mastopexy? That's breast lifting, may be performed with or without augmentation. Essentially, mastopexy is lifting. So there's many different approaches and incisions. An incision can be made only around the areola. Again, the nipple, I think everybody knows what that is. The areola to plastic surgeons, that's the tan part around the nipple. A lollipop incision or a tennis racket incision. The anchor incision means you get all the way around and up and down, and a curved incision in the inframammary fold. There's all kinds of ways to do this. Now, so here's a gal who did not want to be a lot smaller, but she wanted to be higher. And as you know, let me back up. She started out different on the right and left. Typically, if you start out different on the right and left, you're going to have some differences right and the left. We want to use the inframammary fold as kind of a landmark, and we judge what approach to use because of that. So again, mastopexy is a breast lifting where the nipple areola complex is higher, and sometimes the breast mound itself. This can be done with or without an implant. So for example, here's a gal who wanted more volume and she wanted to be higher. So that's a mastopexy augmentation. So the augmentation can be done alone, mastopexy can be done alone, or it can be done in combination. And later, I'm going to talk about breast reduction. Breast reduction is when you get to be smaller, higher, and lighter, and you also get to be higher. That's kind of a combination approach. So we go from there to there, higher and more volume. So all kinds of varieties. Sometimes women just want a little bit of a lift. Sometimes they want to need a lot of lift. Sometimes women want the nipple areola complex to be sort of centered more over the breast mound. Sometimes it doesn't seem to bother them. So again, mastopexy is lifting the breast mound and the nipple areola complex. This is a gal who had what we call constricted breasts. The inferior pole, the inferior skin in between the nipple and the inframammary fold is really tight. That's kind of a congenital difference. So for her, we helped to lift up her nipple areola complex and put in implants. All kinds of different sizes and shapes and different approaches. But I'm doing this so you get an idea. There's different incisions to be made. This is right away after surgery. So we don't judge right away. Now she had a lift only. She didn't want to be bigger. She just wanted to be higher. Here's a gal who wanted to be just higher. And as I've said, different approaches, custom designed approach. So in the consultation, I ask women to use descriptive terms. Do you want to be higher? Do you want to be bigger, fuller, rounder? Do you want to be smaller and higher, etc.? And then we can custom design an approach for you. Okay, so here's another Rodin sculpture. So I've talked about breast augmentation. That's when we make breasts bigger, fuller, rounder, and a little bit higher. There's two general categories of breast augmentation. One is the use of implants, and the other category is with the use of a woman's own fat transfer, fat grafting. Then we talked about breast lifting. That's essentially making the nipple areola complex higher and sometimes the breast mounds. So that's mastopexy, breast lifting. Now we're going to talk about breast reduction. Breast reduction or reduction mammoplasty has pros and cons. Remember I said everything we do in plastic surgery and life has pros and cons, advantages and disadvantages, right? Any car you buy, you want a truck, anytime you arrange for a flight, there's pros and cons to different decisions that we make. So for breast reduction, the advantages or the pros. Breast becomes smaller, higher, and lighter. Smaller, higher, and lighter. the breast reduction operation has some downsides, the cons. There's permanent visible scars. There's guaranteed asymmetry. In other words, this is a handmade operation. I do this by hands. It's not done by a computer. We can do the computer studying ahead of time, and we can try for very close symmetry, but there's always some differences between the right and left face, right and left breast, right and left hand, etc. Possibility of delayed wound healing. Depending on the approach that we use, where the 3 incisions come together, sometimes it takes a few weeks for that to heal up. There's a possibility of change in nipple sensation with breast reduction. Now, for any woman of childbearing age, if she's going to have kids, may have kids, if she wants to breastfeed one day, if she thinks she's going to be pregnant again, those changes are unpredictable. Sometimes women can breastfeed, sometimes they can't. Sometimes with pregnancy, a woman gets bigger again. Sometimes only one side gets bigger. So it's the same if you don't have a breast reduction. Some women have trouble breastfeeding. Sometimes with pregnancy, they get big on one side, not on the other, etc. So those are the potential downsides to breast reduction or the cons. It's popular, in the popular media, People magazine, etc. Now I Can Be Free. I don't promise women that. However, I will say that breast reduction carries with it some of the highest satisfaction rate nationwide of any operation that plastic surgeons do. That's because a lot of women feel they're too heavy and they have the bra strap problems and they have trouble getting bras and they get rashes and they feel like they're carrying a lot of weight around. So it's a reliable operation to relieve those types of symptoms in general. Now, when I talk about body contouring, I talk about the open approach and the closed approach. And that's a whole other lecture. The open approach is where I make incisions and I do tummy tucks, thigh lifts, buttock lifts, etc. The closed approach is essentially liposuction. So every once in a while, I'll see a woman in the office who wants to have her breast reduced but doesn't want any scars. And so sometimes we can try, I examine her and I can give her an idea if we can do the body contouring, if we can reduce her breast with the so-called closed approach. I use that approach many times with men who have gynecomastia, enlarged breasts, enlarged anterior chest. Almost always with men I do the closed approach where we suction. So it can be helpful for women also. I don't always need to make incisions for a breast reduction. But there's many different ways, many different patterns. Essentially in breast reduction what we're doing is bringing the nipple areola complex higher and we're removing what's underneath. And so we raise the nipple areola complex, remove the tissue underneath, sculpt, mold, shape, and tailor. This is what we call the Weiss pattern, the full anchor incisions. As I said, sometimes we go just with a circumvertical around the areola and up and down. So let me show you some examples. Here's a gal who feels like for years she's been carrying around lots of weight. She has bra strap problems. She gets rashes. She feels like she has problems with her upper back, her neck, etc. So there she is about a month later. So we go from there to there. So you can understand for a woman with what we call symptomatic macromastia, in other words, her breasts are so big they're causing symptoms, you can understand why it's a high satisfaction rate operation. So the markings, as I said, we in general transpose the nipple areola complex higher, remove the tissue underneath. Some women come in and they say, remove as much as you can. Other women come in and they say, I'm a triple D, I just want to be a B cup. So we need to plan it out. Here's another woman who I used a different technique. It's called the apron technique. She felt like for years she was carrying around all this extra weight. So there she is. And all she has is scars around the areola and then underneath. She didn't get the part that goes up and down. You can imagine a gal like this carrying around this weight. She feels like she's carrying a kid around, one on each shoulder, strapped to her, strapped to her shoulder, or at least sisters. Yeah. So, and then some women, they come to me, they say they don't want to be a lot smaller, they want to be lighter, they want to be a little bit smaller, etc. So, again, we take our time in consultation.
Doesn't this eventually go away that's around the nipples right there?
Okay, so breast scars tend to fade. These are fresh, relatively fresh incisions, about a month old.
And how about stretch marks? If a woman, say, got stretch marks with her pregnancies, and do you remove them
Okay, so the stretch marks that are on the skin that's removed, of course, are gone. The breast reduction can take tension and weight and mass off to lighten up the skin, lighten up the load on the skin. There's other things we can do for stretch marks. We try to stimulate the dermis with laser, etc.
Can you do that when you're doing lifts as well?
Yes, because a lift takes away skin, and we make skin incisions and then transpose the nipple areola complex higher. But part of the reason I show these relatively fresh post-ops is because I want women to know that for mastopexy and breast reduction, there will be incisions. And every time I make an incision, there's a scar, even though I'm a plastic surgeon. And scars...
Can you get rid of the scar? Like once that's healed, can you come back and like have scar removal? I mean,
Okay,
is there a procedure for that?
so that's a great question. There's such a thing as a scar revision. Sometimes we do laser, sometimes we do steroid injection, even dermabrasion, topical treatments. We have something called biocorneum that works very well. There's some silicone sheaths that work well. But in general, scars are unpredictable, and every time we make an incision, there will be a scar. They tend to fade, but sometimes we're surprised. But we do our best to close very well. But it's oftentimes influenced more by a woman's own innate healing. Like if she has very thick dermis, she's going to make heavier scars. If she has paler skin and thinner dermis, she's likely to make lighter scars. So this gal has problems with the veins in her breasts. So again, lifting. Here's another gal. This gal has lots of weight to carry on her shoulders. So she had some pre-existing asymmetry. She gets some afterward. But the size of the areola, see the areola, the tan part around the nipple, that can be greatly reduced if a woman wants.
Wow. That's her after?
Yes.
Wow.
And again, sometimes women want kind of a moderate reduction. Sometimes they want a very aggressive reduction. But every time I make an incision, there's a scar. And I even tell that to men and women who have a neck lift. But we can try to design the scars and the incisions so they don't show. But for breasts, they're
On this particular picture here, I noticed that you've done the surgery, but her nipples are still down here. How can you, if you're doing a lift, can you bring the nipples back up here?
So what we aim for is to have the nipples at about the inframammary fold. And what we need to do is talk very clearly ahead of time to determine where the woman wants her nipples. That's very important to communicate because not every woman wants that. So,
See, she's up. Where's her up?
so that's a different type. It's a different type of macromastia. So she had a different approach, different incisions. So again, what we tend to do is to move the nipple areola complex higher, then remove the skin and tissue underneath. So different types of approaches. So again, we talked about breast reduction. We talked about how a breast reduction results in a breast that is smaller, higher, and lighter. Mastopexy, you get to be a lot higher, but not necessarily smaller. Depends what you want. Breast augmentation, you get to be bigger, fuller, rounder, and a little bit higher. That's why we spend a lot of time in consultation to determine what it is that you want. And we look at your photographs, we look at the pictures that you bring in, we can do the vector computer imager, etc. So, the reason why I show the statue of David, Michelangelo's David, is not because it's my namesake, but because plastic surgery of the breast and chest is also for men. It's very common. So what's gynecomastia? Gynecomastia is the abnormal enlargement in men of the breast and anterior chest. And it's very common. I see this in young guys, adolescents. They don't want to take their shirt off. They don't want to go to gym. They strap themselves. I see it in older guys. I see it in men of all ages. Some guys have problems with their jackets, etc. But gynecomastia is abnormal enlargement. So here's a guy who is bothered by his breast buds, and so what I try to do is reduce the breast mounds in a man with a closed approach. So that's with suctioning. Very small access incisions to get in a cannula. A cannula is a tube attached to a vacuum, and I can vacuum and mold and shape and tailor. So here's a guy who's really strong. He works out, but he has more breast tissue than he wants. So that little axis incision there towards the armpit, that tends to fade quite well. Sometimes I make a little incision just where the tan changes to the paler skin at the areola, sometimes at the lateral inframammary fold, almost always in the armpit. So here's a guy just very self-conscious about his body. He works out a lot. He's just more pleased and is much more willing to take off his shirt. Here's a guy who has some kind of lipodystrophy, excess fatty deposits, and he felt that he had just far too much breast tissue. It's actually very common. Gynecomastia is a common condition, as I said, for adolescents, for older guys, guys of all ages. That's the closed approach. Now, something else for guys, it's called Poland syndrome, actually relatively common as well. It happens sometimes with women. Women don't seem to be bothered as much. That's when the pectoralis muscle and the breast and at the shoulder girdle is smaller on one side than the other, and it can be markedly different. Sometimes it extends to the ribs, sometimes it actually even extends into the hand, and the whole arm is smaller on one side than the other. So it's the absence or hypoplasia, undevelopment of that chest wall, the breast, the shoulder girdle, etc. So here's an example of a guy who has no pectoralis muscle on his left, and he's got a normal one on the right. And so for him, I transposed, and here it is reversed. So for him, I transposed the latissimus muscle that we use for breast reconstruction to the front of his chest instead of the back of the chest. It can be detached for breast reconstruction, Poland syndrome, etc. That's living muscle. It's his. It's still attached to his body, and we transpose it forward like a fan. And so there he is, much more symmetric, much more balanced. Okay, so let's see. Laura, can I talk for 5 more minutes? Is that okay? So I talked about plastic surgery of the breast for men. We talked about plastic surgery of the breast for women. I just want to talk a few minutes about breast reconstruction after cancer treatment. As I said, we typically give this talk in October, but we like to do it in the summertime as well. So this is a DVD that we made featuring Dina Eastwood. It's called Breast Reconstruction, Know Your Options, a guide for the woman with breast cancer. We have a website, breastreconstructiondvd.com. In summary, there are 4 major issues in breast reconstruction. We need to think about the type of breast reconstruction. In this country, there are 3 common types of breast reconstruction. Implant-based reconstruction, tummy tuck flaps, where we do kind of a tummy tuck, and instead of throwing that tissue away, we tunnel it under and use it to reconstruct the breast mound. I'm going to do one of these tomorrow. Also the latissimus flap, we take tissue from the back and transpose that forward. You recall I did that for that man with Poland syndrome. So we can do that and bring tissue forward for women. So the type of breast reconstruction. Now, consider the other side. If a woman has a lumpectomy or a mastectomy, we can also offer her one of the cosmetic operations, mastopexy augmentation or reduction, on the other side for symmetry. Because now insurance companies are paying for what they call symmetry operations after breast cancer treatment to give women more a sense of being balanced and harmonious and even. Timing. Breast reconstruction can start at the time of the mastectomy or in a delayed fashion. Sometimes women say, I'm going to have breast reconstruction started at the same time as my mastectomy, and we can do that. Other times they say, no, I just want to get through the mastectomy, and I'll think about it for the future. Later nipple areola reconstruction, NAC, nipple areola complex reconstruction. We're really good at making nipples and areolas from skin grafts and local flaps, etc. So these 4 major issues. So, number 1, the type of breast reconstruction: implants, latissimus flaps, and abdominal flaps. 2, consider modifying the other side, augmentation, reduction, and lifting. Remember, we went through those categories: augmentation, use of implants, or a woman's own fat, reduction or lifting, etc. The timing can be immediate, delayed, and there's something called a hybrid, where we can kind of get it started at the same time as the mastectomy, but we don't do a lot for a while. And then later nipple areola complex reconstruction, we can do nipple flaps, areola flaps and grafts, and also tattooing. So for example, I just want to show you a few cases. This woman had immediate breast reconstruction on the right. She had a mastectomy, and I did implant-based reconstruction same time. And she wanted to be a little fuller and larger on the left for symmetry. Now this is delayed breast reconstruction. She had the mastectomy years prior, and then she came to me. We did the tummy tuck flap. So let me back up a minute. She had a little bit of extra tissue in her tummy. So see the scar that she gets on her belly? So we do a tummy tuck. Instead of tossing that tissue away, we use it to rebuild her breast mound. Now somebody asked me about stretch marks. This gal's had a few pregnancies. She wanted the advantages of the tummy tuck. So we did microsurgery breast reconstruction for her. And so we use that tissue from her tummy to rebuild her breast mound. This is bilateral breast reconstruction. She had the tummy tuck flap for both sides to rebuild her. This was reducing and doing breast reconstruction for her, so she got the symmetry procedure as well. So there's all kinds of choices in breast reconstruction. Now, how do we build a nipple, or the nipple areola complex? This is a gal who had the abdominal flap reconstruction. So what we do either in the office or in the surgery center, sometimes the hospital, we can do revisions. I've measured the other side. So the nipple typically I do with a local flap, and then the areola I do with a little skin graft. So this is called a skate flap. It's one of my favorite ways to do the nipple. I raise some tissue, and the central core has a little bit of extra fat on it. Woman's own tissue. It's still attached to her body. It's a skate, like a manta ray in the ocean. It's that type of skate. So with a local flap, I transpose that around to give the nipple projection, skin graft the areola, and there she is. So we take the skin graft from wherever a woman has a scar already. She had the tummy tuck. So there she is in the early stages of healing. And there she is later. So the scars tend to fade. Somebody asked me about scars. So we're a big believer in breast reconstruction, and we're also a big believer in aesthetic and cosmetic surgery of the breast for women and for men. And I'm very grateful for your attention. Thank you very much for being here. Laura's here. There's treats, there's drinks, there's food. Mario, thanks for being here.